to mind is ancient Mesopotamia and cultures there. Can I have your attention, please? What comes to mind is ancient Mesopotamia cultures and civilizations like the Sumerian civilization, Akkadian civilization, Assyrian civilization. Of course, those cultures and civilizations were a big part of the country, of the history of this country, a glorious time in the history of this country. But I'm not only talking about ancient times. This is a country that has been house to Bayt al-Hikmah, or House of Wisdom. House of Wisdom was the brightest star in the Islamic Golden Age. You've all heard about the Islamic Golden Age, the period of time that Muslim countries were the most advanced part of the world in terms of science, in terms of education, different areas in science, including medical sciences, astronomy, physical sciences, chemistry, everything that are considered today part of empirical sciences. And Bayt al-Hikmah, or House of Wisdom, was the brightest star in that period. Scientists, physicians, astronomers, mathematicians, physicists, chemists from all over the world, philosophers, were coming here, well, not specifically to this city. House of Wisdom was located in Baghdad. They were coming to this country for their scientific activities, for their educational and training, educational activities and training. And this needs to be kept in mind, especially by young Iraqis. That House of Wisdom doesn't exist anymore. There was an unfortunate event, the Mongols attacked Genghis Khan and his offspring, who attacked the caliphate at the time, and they basically destroyed the House of Wisdom. But it's your responsibility today to revive that, to start it again. In this university and other universities, you need to regenerate that bright star again. And this is very important. Don't be only inclined towards the Western civilization. Today, the brightest star in the world in terms of science is not here in the Middle East. It might be in Oxford or Harvard or Stanford University, somewhere in the Western countries. But you guys need to, and we all need to, revive the Islamic Golden Age. And especially you guys as young Iraqis have a heavier responsibility, because this has been happening here. So keep that in mind. You all have, and we all have, some personal careers. You're going to be doctors, physicians, specialists in future, scientists, teachers, university professors, and you'll be doing work in that capacity. So that's very good. But we also have a social responsibility. We have a responsibility towards our society, towards our nation, and towards the bigger world. And that responsibility is to revive. Part of that responsibility is to try to regenerate, recreate that bright star. It doesn't have to be in Baghdad or in Karbala or in one specific city. It doesn't have to be a single organization. It can be multiple organizations. But the responsibility falls on you as scientists of the future and as physicians of the future. So this was the piece of advice that I had for you guys in the beginning of the class. So today we are going to talk about immunology, which is well, important part of medical sciences, and I'm going to focus on what is called hypersensitivity. Hypersensitivities are part of these last 3 classes that you're going to have. So in the morning I taught hypersensitivity to group A. Now I guess you guys are group B, that's true. And then we'll have another class for immunodeficiency today, and tomorrow we'll be talking about immunology of infectious diseases. So these concepts are kind of related to each other. But the way that I want to start this class is by introducing you to a concept named model, M-O-D-E-L. In science, we use models a lot. What is a model? A simplified representation of reality. Reality is always complex. Like immune system, it's part of reality. It's very complex. It's a set of cells and molecules and tissues and organs. They're always interacting with each other. And both the structure and the function that it has is complex. In In science, we use models as simplified representations of reality. As simplified representations of reality. Because, well, models would help us understand better. Models would help us explain things better. Models would help us analyze things better. And that is why we use scientific models. So, important thing is that we have different types of models. Like here I have some physical models. This is a physical model of the heart. It's a simplified representation of the heart. You go to classes, anatomy class, and then afterwards you go and take this model, look at it, you can understand left ventricle, right ventricle, aorta, different veins, valves a bit better. This is also a model. This is a model of the solar system. So you have sun in the center, at the center, and then you have planets revolving around it. And actually, if you sort of rotate this handle, you would see different planets orbiting around the sun. This is another physical model. And physical models are usually used for educational purposes. Here I have another type of model. Models are not always physical. Sometimes models are conceptual. You have the concepts in your mind and you make some drawings on the whiteboard or on a piece of paper to explain what you have in your mind. Again, these are simplified representations of reality. These are models of the atom. Like at the turn of 20th century, people believed that atoms are like billiard balls bouncing to each other and they cannot be divided. Later, they recognized that there are positive and negative charges. They thought they are distributed all over the atom. Then they realized that positive charges are at the center of the atom, and later better models were developed. These are called conceptual models. Again, these are simplified representations of reality. And then finally, we have mathematical models, like physical laws. These are models as well, simplified representations of reality, like the law of motion and also the gravitation. These are all models. One thing which is important about models is that models are only approximations of reality. They are not exact copies of reality. This is very important. This is very important. Don't mix up models with reality. These are just approximations of reality. And this is a translation that I could find for that. These are only تقریبات للواقع. These are not exact copies of reality. But they are very useful. They help us understand better. They help us analyze things better. They help us teach things better. And here I'm going to use a model for the immune system that you have seen before. This is a conceptual model. Immune system is a system, a setup for collection of cells and molecules and tissues and organs, which has the responsibility of defense. And in this model, it has been divided to two parts, innate part and adaptive part. The innate part is always there. It's ready to act. It doesn't take time, or it doesn't take much time to prepare itself. But the adaptive system usually takes some time to prepare itself. The innate part is composed of two components. Barriers, like my skin, it's part of the innate immune system, or the mucosal layer of my gastrointestinal tract, and the secretions that they have, like the acid in the stomach, or enzymes in the gastrointestinal tract. There are also some phagocytes, like neutrophils, and together they generate what is called innate immune responses. One thing that this part does not have is memory, and the other thing that it does not have is specificity. What do I mean by being specific? I mean that, like, imagine that you're a granulocyte and you see an E. coli, you perform phagocytosis. Later you see another microbe, like a brucella. You perform exactly the same process of phagocytosis without any change. You don't care about the specific type of the microbe. You don't customize the response based on the microbe that you're seeing. That is why we say that innate immune responses don't have specificity. They don't act specifically. And they don't have memory as well. Like if I say something, if I see something, I would memorize it. These cells don't memorize anything. If I'm a granulocyte and I'm phagocytosed and E. coli today, if I see exact same microbe 2 weeks after that, it's as if I'm seeing it for the first time. I don't act any differently. It's as if it's the first time. But this part of the immune system is different. The adaptive part, the responses that we have, are customized to the specific type of entity that it's being encountered. It has two parts, B lymphocytes and T lymphocytes. B lymphocytes produce antibodies, and antibodies are present in body fluids. That is why it's called humoral immunity, humor meaning fluid. Another part is generated by T cells. It's called cellular immunity. Responses are specific to the entities. If I generate an antibody against a virus like influenza virus, it would be specific for that one. It's not going to protect me against hepatitis virus. That would require the antibody of its own. And they also keep a memory of their encounters. If I see an antigen today and produce antibodies, if I see the same antigen 2 weeks later or 2 months later, or maybe 2 years later, I would generate a stronger antibody response, faster antibody response. I recall my previous encounter. So this part doesn't have memory and specificity, but it's ready to act. This part does possess memory and specificity, but it usually takes some time to prepare itself. One thing, by the way, keep in mind is cellular. The name in here is kind of a bad name, because cellular, it means something related to cells. Well, these are cells, these are cells, these are cells, and even barriers are made of cells. So why this specific one has been named cellular? It has a historical reason. It was in the beginning of 20th century, people had recognized that there are 2 types of specific immunity. One type of immunity, if you want to transfer it between people from one person to another, it's sufficient to take fluids, it's sufficient to take plasma of the blood and inject the new person with it, and the new person would be immunized. They called it humoral immunity. But then there was another type of immunity that you could not transfer it by transferring body fluids. So you had to take cells, the white blood cells, and inject the new person with the white blood cells, the leukocytes themselves, if you wanted to transfer immunity. For that reason, it was named cellular immunity. So this is transferable by fluids, but this is transferable by cells. And later they recognized that these are T lymphocytes that are responsible for that type of immunity, but the name remained. It's a historical name, humoral versus cellular. So this is a model of the structure of the immune function, of the immune system. Do I have a model for the way that immune system works? Structure, function. This is a model for the function of the immune system. In this model, we have 2 axes. One axis is self versus non-self. In the past, people believed that immune system only need to recognize self from non-self. Cells are good, non-cells are bad. So we have to generate immune response against non-self. But later they recognized that this is not true. Not all self entities are good, and not all foreign entities are necessarily bad. We have some self entities which are dangerous. I made it non-safe. And we have some foreign entities which are okay. So I need a second axis. Safe, non-safe axis. And then I have things like this. A lot of molecules that we have in our body, they are self, they belong to me, and they are nice. Like hemoglobin in the red blood cells, myoglobin in muscles, enzymes, a lot of things. And then here we have infectious agents, viruses, bacteria that cause disease. They are foreign and they are dangerous. But we have 2 more areas left in here. Self things which are dangerous and foreign things which are nice. Could you take your pens and a piece of paper, or maybe using your laptops, and give me 2 examples for this and 2 examples for this? You have 30 seconds. 2 examples of each of them. 2 examples of self entities which are dangerous, and 2 examples of foreign entities which are okay. They're not dangerous, they're fine, they're nice. 2 examples of each. said that? I heard the word, but I didn't recognize.
Cancer.
Cancer cells, excellent. Very good. What else? What else? Injured cells. Neoplastic means cancer. A cell that is proliferating uncontrollably itself. But it's dangerous. Also cells that are injured for whatever reason. They are self. But you should not leave them alone. You have to go and do something about them. How about this part? Yes, please.
The flora. The flora. The bacteria that we have in our
The flora, exactly. Microbial flora, very good. Microbes that we have are in our intestines at the surface of the skin, it's normal flora. Yes, please. Food, exactly. When we eat something, a lot of proteins which are non-self enter our body. Anything else? Yes?
the bacteria that is present in the mouth.
Bacteria that's present in the mouth, which is usually part of the normal flora, sure. Microbial flora, food, pollens from the trees, pollens, which we inhale, especially during spring. Drugs, penicillin. Somebody has an infection, we give them penicillin or antibiotics, drugs. They are non-self entities, but they are safe. So the model here says like this. If you are on the right side, non-safe part, you need an immune response. If you are on the left side, there is no need for immune response. And it's called tolerance. Immune response here, tolerance there. So what is the Arabic word for tolerance? What is the Arabic word for tolerance? Can't hear. Say, speak up.
Forget.
Forget? No, no, no.
The body don't attack
No, 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 I know the Arabic word. It's tahammul. Very good. Very good. Okay. So the word tahammul in Arabic or tolerance in English, it has a sort of a negative meaning. Like, I don't know if you guys are living in dormitories or not, but or you've rented a place. Sometimes you have a roommate that you don't like, but you have to tolerate. Sometimes in the dormitory or in the room that you or in the place that you rented, you have a roommate, or maybe in the classes you have a classmate that you don't like, but you have to perform tahammul, you have to tolerate the person. So in this context, tolerance has a negative meaning, but tolerance here doesn't have a negative meaning. It means that I like you and I support you. That's the meaning of tolerance in here. It's not like, yeah, okay, well, I have no choice to tolerate you. No, it's not like that tolerance. It's a positive way of tolerating, supportive tolerance. Immune response here, tolerance there. So this is the model, the simplified representation of reality, of the function of the immune system. And sometimes things get mixed up. Sometimes diseases happen. Why diseases happen? Because infectious agents are considered safe. And we do not develop sufficient immune response against them. Or sometimes these guys are considered safe. And our body doesn't generate sufficient immune response. How about this one? What happens if these ones are considered dangerous? What would happen? Immune response against our own antigens, autoimmune problems would happen. And finally, sometimes things which are in here are considered dangerous. These are diseases of the immune system. Here we have infectious diseases if you don't have sufficient immune response. Here the person might have cancer, autoimmune diseases, and some people have called this hypersensitivity. Immune response against things which you should not have an immune response against. So this is one way to put hypersensitivity, but there is also another way. Hypersensitivity is any type of unwanted immune response. So hypersensitivity, by looking at here, this is a narrow definition of hypersensitivity. But the broad definition of hypersensitivity is not limited to this. The broad definition of hypersensitivity is any unwanted immune response. Any unwanted immune response. So what kind of immune response could be unwanted? Let me say it differently. Hypersensitivity means any type of inappropriate or exaggerated immune response that can cause damage. Any type of immune response which is inappropriate or exaggerated. I don't know if the translation is good enough, to translate. So if you look at it this way, if I have an immune response against microbial flora, against food, against drugs, this is an example of hypersensitivity, and people have named it so. But it's not limited to that. If I have an immune response against my own antigens, this is again inappropriate. I don't want it. That is unwanted. This is another example of hypersensitivity. How about this, guys? We need immune response against infectious agents. It's required. But if it's too strong, if it's too much, it's an exaggerated response. It's too strong. It's not only damaging microbes, it's even damaging my own body. This is also hypersensitivity. So in this sense, we can have hypersensitivity here. We can have hypersensitivity here. And in this part, basically hypersensitivity means autoimmune diseases. And we can also have hypersensitivity here. Too much immune response against the microbe. It's damaging. And if it's damaging, it's hypersensitivity. So in this class, we're going to look at hypersensitivity by this definition, the broad definition. And what I'm going to tell you is that we have 4 types of hypersensitivity in terms of mechanism. 1, 2, 3, 4. 1, 2, 3, and 4. The type 1 is caused by a class of antibodies which is named IgE. The type 2 is also caused by antibodies, but antibodies other than IgE, like IgM and IgG. Type 3 is also caused by antibodies, but antibodies that have bound to the antigens. When an antibody binds an antigen, it's called antigen-antibody complex or immune complex. It can also cause problems. Type 4 is caused by T cells. So 1, 2, 3 are related to antibodies. If it's IgE, it's type 1. If it's other antibodies, it's type 2. If it's antibody bound to the antigen, it's type 3. And type 4 is by T cells. So we want to see examples for each of these ones. Type 1 is caused by IgE. These are also named allergy. So allergies are a subgroup of hypersensitivities. Allergic reactions. Where do they come from? We know that B lymphocytes produce antibodies. Some of the antibodies are secreted like in the saliva or gastrointestinal secretions, and they target antigens there. When they target and inactivate the antigen, it's called neutralization. They make them neutral. Sometimes antibodies are present in serum, blood, fluid, and they perform neutralization, meaning inactivation there. Sometimes they facilitate phagocytosis, it's called opsonization. Sometimes they activate complement. Sometimes they bind to the cells that have bad antigens at their surface. It's called antibody-dependent cell cytotoxicity. And sometimes, and this is the important one for this class, they bind to worms. And then they recruit eosinophils and mast cells to kill the worms. Different classes of antibodies perform these different functions. This is the work for IgA, which is secreted. This is the work for IgE. This is a worm killer, killing worms. And then IgG and IgM do some other stuff. So type 1 is related to IgE. How is it related? Well, we know that if we have a worm, here I have an antigen presenting cell. This is MHC molecule. We have some cells named T helper 2. The T helper 2 produces cytokine. We will see about this in in more detail tomorrow, named interleukin 4. And interleukin 4 tells B cells to produce IgE. Why should I produce IgE? Because there is a worm in here. The worm is covered by IgE. And then we have two cells, eosinophils and mast cells, that can bind these IgE molecules. What happens next? There are granules inside them. The granules inside the eosinophils are toxic stuff. Toxic for whom? For the worm. Eosinophils release their granules. Mast cells do the same too. And these granules can kill the worm. That's the process of defense against worms. Defense against worms. This is okay. This is good. This we want it. This is not hypersensitivity. It's part of defense. Helminth means worm. Part of defense against worms. However, sometimes things get mixed up. IgE is produced against things that don't require any IgE. Here I have some pollens, and here I have a bee that has a sting. Sometimes things get mixed up. IgE is produced against the pollen, or it's produced against the tiny bit of poison that the bee enters our body if a bee or a wasp sting you. What happens? Imagine that these are some pollens, harmless stuff, completely harmless. But the immune system makes a mistake and starts producing IgE against the pollens. We don't know why, but this is an immunological mistake. Eosinophils and mast cells come here and they release their granules. And if it's too much, it will cause problems. There is no worm here to kill. These are pollens that have entered my nose or my lungs, or maybe these are allergens in the food that I have consumed, and this thing is happening in my intestines. What happens in here is a response to, is a type of unwanted immune response against something which here we call it allergen. Mast cells release their stuff. Mast cells release their stuff. How this happens, well, we don't need to go to too much detail. The story is that when B cells produce IgE, mast cells have receptors for the IgE. It binds this way, and then the allergen can bind these things together, and the mast cell releases its granules. A lot of things, including histamine, and some other stuff. What is the effect of histamine and those other stuff? One thing is that it dilates blood vessels. It's called vasodilation. But it's not the only effect. It also increases the permeability so that blood fluid can come out of the vessel and enter the intercellular space. It can lead to contraction of smooth muscles, maybe in my lungs or maybe in my intestines. There are a lot of smooth muscles there, and it causes inflammation. So these things can cause problems that I'm going to show you in this table. Several examples of IgE-mediated reactions. Here I have the name of the allergen, how it enters the body, and the response. Here I have the name of the disease. And here I have the location, the target organ. Sometimes the allergen, like a drug, enters the body through veins and distributes all over the body. It goes everywhere. If you inject a person with intravenous drugs, sometimes by stings, venom, which is the poison that is produced by insects and stuff, if you get stung by a bee, for example, and if it's too much poison entering your body, sometimes it distributes all over your body. This is rare, but it can happen intravenously. And what happens is that if the person has IgE against that, the IgE will go and bind to the venom or to the target, and it calls mast cells and eosinophils to come and release their granules. Mast cells all over the body including histamine and some other stuff. And what happens is very bad. First, edema, swelling in the body. Edema is not dangerous if it happens in my hand or in my legs, but it is dangerous if it happens in my throat. It will lead to tracheal occlusion. I can't breathe anymore because there is edema in my throat. Histamine makes the blood vessels dilated and body fluid comes out of it. If it happens all over the body, the blood pressure would drop. And it can lead to what is called a circulatory collapse. This is an emergency. It's named anaphylactic reaction. It's very dangerous. So anaphylaxis is when you have something all over the body, mast cells, eosinophils releasing their granules all over the body, edema in places which could be dangerous, like in trachea, and decrease in blood pressure. This is the most severe form of IgE reactions. But not all IgE reactions are as bad. Sometimes you get a bite by an insect, but the poison is tiny bit. It doesn't go all over your body, so it remains there. The route of entry is subcutaneous. Mast cells would go there and they release their granules. And locally, you have some tiny edema. You see a little bump in your skin. Sometimes it happens if you touch plants that have sort of allergens. And it's called wheal and flare. What is the Arabic word for wheal and flare? Would you look it up for me? W-H-E-A-L and F-L-A-R-E. What is the Arabic expression for that? I'd rather learn it.
انتفاخ وتوهج.
Say it again.
انتفاخ وتوهج.
انتفاخ و
توهج.
توهج.
Yes.
Excellent. انتفاخ و توهج. Wheal and flare. Wheal means it's a little bump.
Yes.
Flare means it's a little bit of redness. But it's localized in one region. So this is the skin. Sometimes things enter the nasal cavity by inhaling, like pollens or some sort of dust. Or there are tiny animals. Could you look this up too? Could you search mite, M-I-T-E? I don't have a slide for it. Mite. Mites are tiny insects. They're not really insects. They are tiny arthropods, M-I-T-E. You can't see them with naked eye, mites. But they're present in, like not in here, but in old buildings and carpets and stuff. Mites are all over the place. Did you find the mite?
Yes.
Right. And they release antigens usually in the form of feces. So if you basically move that carpet or walk on it, sometimes this feces enters our respiratory system. And locally, if there is IgE, again, mast cells would go there, histamine is released, and I have a little bit of edema and secretion in my nose, so I get a runny nose. Or my nose gets itchy. This is called allergic rhinitis. Rhino means nose, rhinitis, inflammation in the nose. This is, again, it's not dangerous. It's discomforting. The person is annoyed if you have to have a sort of a basically Kleenex or something all the time, like rubbing your nose, and it's itchy, so it's discomforting, but it's not dangerous. What happens if these things go all the way down? Upper respiratory tract is from like larynx above, like nose and pharynx, it's upper respiratory tract. If you go down to bronchi and bronchioles, it's lower respiratory tract. If it goes there, the situation would be more severe. It will be associated with constriction in the bronchi, lower airways. And what will happen is called allergic asthma. Allergic asthma, person has difficulty in breathing. Usually it's not that severe, but there are instances that the asthmatic person becomes really difficult for him or her to breathe. And finally, if something enters through the oral route, if I eat something, sometimes milk antigens, egg, fish, the same stuff happens in my gastrointestinal tract. Contraction, of the muscles there. It causes vomiting, diarrhea, and also interestingly, sometimes things which enter through my gastrointestinal tract, if I have IgE against it, I might have skin symptoms. Although the place of the entry is gastrointestinal tract, the symptoms are skin symptoms.
This is not hypersensitivity.
This is hypersensitivity.
This is all.
Yeah, yeah. This is again hypersensitivity. So not all GI problems are hypersensitivity type 1. We will get to that. But the ones I'm showing you, what is called food allergy, is a type of type 1 hypersensitivity. It's caused by IgE. Alright. So let me show you some symptoms. We have a word in here named hives or urticaria. What is urticaria? It's a skin problem, reddening of the skin plus some swelling, and it's also itchy. It's called urticaria. So this is the Arabic Wikipedia page for that. How do you pronounce this? Shara, is the commonly used word in Arabic? Is it okay? It's equivalent of urticaria. It's equivalent of urticaria. So it means that mast cells are releasing their granules under the skin, and then blood vessels are dilating and some fluid is being released. So this is what happens in some skin allergies as well as food allergies. Sometimes it's all over the body, and it's very discomforting. It's itchy as well. This is an example of edema, swelling, because blood fluid has come out. Like if you get stung by a bee, well, it's very painful. But if you have some IgE against those antigens in the bee venom, then you might have edema like that. You can't even open your eye if you've been stung in here. Or if you're stung somewhere else, you might have edema. This is another type of type 1 hypersensitivity. This is the dangerous situation. This could be life-threatening. These are examples of systemic allergic reactions. Systemic means all over the body. You have edema in here. You have edema in here. You might also have edema in here. Trachea. And the person cannot breathe anymore. And these things can be associated with a decrease in blood pressure as well. So this is a dangerous situation. This is an emergency. You have to act quickly if you want to save the person. Like this could be due to penicillin injection. It's an antibiotic, penicillin injection. This could be due to bee sting. And it's a dangerous situation, anaphylactic reaction. So how can I find out about the allergen which is causing this? Sometimes we know about the allergen, like I've injected the person with penicillin and he's having reactions in the skin, or maybe anaphylaxis, so I know that it's been penicillin. But sometimes we don't know. The person has symptoms of allergy, like bronchial asthma, or skin allergy, or food allergy is the most common one. You eat stuff and you get vomiting and pain and diarrhea and cramps, and you know that it's not infectious, it's allergic. What kind of allergen is causing it? We have a test named skin prick test. Prick means like a needle, pushing a needle into the skin. So what you do is that you get allergens, you prepare different types of allergens, food allergens, pollens, allergens from insects, different drugs, and you put these allergens which are soluble like drops on the skin. 1, 2, 3, 4, 5. And then you get a needle and you poke the skin. Not too much, but a little bit. So that a tiny bit of antigen gets under the skin. And then you wait for 20 minutes to 30 minutes. It happens fast. And then you see that like in this area that I have put allergen number 5, nothing has happened. So it means that the person is not sensitive to allergen 5. For allergen 6, nothing. But for 7, I don't know if you can see it from there. Look at the slides later. You see a bump with some redness. This is wheal and flare. Wheal and flare. Wheals mean bump, flare means redness. This one here too. And then based on the response that you're getting to skin prick test, so this is like 20 allergens, 1, 2, 3, 4, 5, all the way to the end. And then you poke the skin a little bit. And then you see that maybe this one is showing some reaction. That means that the person is sensitive to that allergen. So type 1 hypersensitivity happens only here. against things which are external and they are safe. We don't have in here or in here. And this has a name, by the way, another name. It's called immediate type hypersensitivity. Immediate, it means it's fast. It's fast. Later we will have another hypersensitivity which takes time. It's called delayed type hypersensitivity. But this is immediate hypersensitivity. It happens fast. In 20 minutes you'll see the results. Let's come to type 2 hypersensitivity. I'm going to say this and then you can have a break if you want. Do you want to have a break?
Yes.
You want to have a break? Is there anybody who doesn't want to have a break? Nobody. Okay. How many breaks do you want to have?
10 minutes. 50 minutes. 10.
No, 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 not the length of how many breaks you want to have.
Yeah,
Just one is enough or you want?
Yeah.
One is enough? Okay. 10 minutes. Yes.
you mentioned that if we
Question here.
if we need to know which type of infection that we have, that we inject the substance. I want to ask which type of substance that we injected to the patient.
So it's not real injection. It's not real injection. It's a test that you put the allergens in here. It's not really injecting. It's a tiny needle that makes the fluid enter the subcutaneous. It's very tiny bit. Very tiny. And then you have like these ones might be food allergens. These ones might be pollen allergens. These ones might be insect allergens. Different types. And then you will figure out which one the patient has a response to. Okay, so let's see this and then we'll have the break. Type 1 is here. How about type 2? Type 2 is also caused by antibodies, but antibodies other than IgE. Other than IgE. What kind of antibodies? Usually by IgG or IgM. So, how could it happen? It can happen here. It can happen here. It can also happen here. It can happen here. It can happen against things which are external, foreign, but harmless. It can happen against our own antigens as well. So it will be kind of autoimmunity. And it can also happen against infectious agents. Infectious agents, you need antibody response. But this is too much. Or this is an antibody response which is causing damage. So it qualifies as hypersensitivity. Let's see the first one. Foreign harmless antigens. Foreign harmless antigens. This is a red blood cell. And these tiny things that you're seeing in here, there are some drugs that when you eat or when you inject, they go and bind to the surface of the red blood cell. Drug molecules. There are some like antibiotics and stuff. These drug molecules are harmless. They are foreign, but they are harmless. But here, immune system makes a mistake. It starts producing antibodies against these drugs. The drugs are bound to the surface of RBC, and the antibody would bind to the drug. And this would be very bad for the red blood cell. Why? Because if you have an antibody bound to the surface of the blood cell, one thing that happens is that complement gets activated. Complement is a set of proteins that when they see an antibody bound to an antigen, they go and get activated there. And one of the ways that complement gets activated is that it generates holes, because it thinks that it's a microbe, so it wants to kill it. And it generates holes at the surface of it. So it generates holes at the surface of the red blood cell, and the red blood cell dies. Another thing that might happen is that red blood cells will be phagocytosed. Because one of the things that complement does is that it activates complement. It has a part which is an opsonizer, makes the eating easier. And here I have a macrophage that sees this, says, yeah, okay, well, you look like a bacteria, I'm going to eat you. But it's not a bacteria. So red blood cells die in here. They also die in here. It has a name. It's named hemolysis. Hemo means blood. Lysis means destruction. Hemolysis means destruction of blood. And if it's too much, it will lead to anemia. Anemia is lack of sufficient blood. You will have a disease named hemolytic anemia. Anemia can happen for two reasons. Sometimes red blood cells are not produced enough. Like if I have iron deficiency. Iron deficiency, I don't have enough iron. Red blood cells will not be produced. That is called iron deficiency anemia.
Also,
Sometimes red blood cells are destroyed. It's called hemolytic anemia. Yes?
also hemoglobin deficiency.
Yeah, sure. There are genetic diseases like thalassemia in which you have hemoglobin problems. Sure, sure. So this is called hemolytic anemia, but it has a name, drug-induced hemolytic anemia. And this is a type 2 hypersensitivity. What was hypersensitivity? Definition of hypersensitivity? Could you write it? Could you write it? I'm going to check. What was the definition of hypersensitivity in Arabic or English? What was the definition of hypersensitivity in Arabic or English? A sentence, one sentence.
Unwanted response.
Write it down. Write it down. I want to check. What was the definition of hypersensitivity? Hypersensitivity is referred to okay, hypersensitivity is referred to any type of guys here. You weren't listening very well. Hypersensitivity is any type of inappropriate or exaggerated immune response. Inappropriate or exaggerated immune response. An unwanted immune response. A bad immune response. Keep this in mind. Alright? So is this a bad immune response? Is this a bad immune response?
Yes.
Yes, it is a bad immune response. It's killing red blood cells. It's causing hemolysis. It can lead to hemolytic anemia. What kind of hypersensitivity this is? Is this type 1 hypersensitivity? No. There is no IgE in here. This is type 2 hypersensitivity. And it's not against RBC itself. It's against the drug that we have in here. But because the drug is binding to the surface of the RBC, the innocent RBC would die. This is called drug-induced hemolytic anemia. Keep this in mind because in the next slide, I'm going to show you another type of hemolytic anemia where the antibody binds to the RBC antigens itself. And these are different. If the antibody is against the drug and the drug is at the surface of the RBC, this is one type of hemolytic anemia. This is not autoimmunity. This is not autoimmunity because the antibody is not against the RBC. It's against the drug and that drug is at the surface of RBC. But then in the next slide, or one of the next slides, we have a different situation. Keep that in mind. I'll get to here. Can we have an antibody response against a microbe which is causing damage? Antibody response against microbes is necessary. It's good. But sometimes it's too much. Or sometimes it's doing something that it's not supposed to do. As doctors in future, you will see these things a lot. Sore throat. What is the Arabic for sore throat? Say it again. Hanjara muhaqqara. Very good. In another class, they said something else about lawzatain, التهاب اللوزتين. Okay, okay. The same. All right. So sore throat is something that you will see very often. The technical term is pharyngitis. We have two types of pharyngitis. Which one doesn't need any particular treatment? It's viral pharyngitis, like the common cold, regular common cold. It's viral pharyngitis. In viral pharyngitis, you usually don't have fever, or if you have fever, it's below 38.5. And what you see if you look at the throat is only redness. It's called erythema. This whitish stuff, you don't see it there. But this girl in here doesn't have viral pharyngitis. She has a fever more than 38.5. And also, when you look, you see some white stuff. This is called exudate. This is an example of bacterial pharyngitis. And the bacteria which causes it are usually streptococci. Streptococci. This is an example of streptococcal pharyngitis. Viral pharyngitis goes away by itself. Bacterial pharyngitis goes away by itself as well. It's called self-limiting. Self-limiting. Write this down. Remember it. Self-limiting. What is a self-limiting disease? Write it down. Write it down. Write it down. S-E-L-F. 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 Not C-E-L-F. S-E-L-F. Dash. Limiting. L-I-M-I limiting. L-I-M-I-T-I-N-G. Limiting. Self-limiting. Self-limiting. What is self-limiting? Was there a blackboard in here? Here? No? Went away? Yeah. Okay. Ooh. I have it written this thing. Self-limiting. What is a self-limiting disease? It means that it goes away by itself without any treatment. All right? So,
Go back.
go back. Back. Oh, okay. Oh, shoot. Source HDMI. Okay, it's self-limiting. What one bad thing might happen? Antibodies will be produced against these streptococci. Antibodies will be produced against the streptococci. They will go and bind to streptococci. So far, so good. No problem. But these antibodies can cause some problems later. Why? Because these antibodies can also bind to the heart. There are some molecules at the surface of the streptococci which are similar to some molecules in the heart. This is called molecular mimicry. Mimicry means like you're imitating someone. Like if I'm mimicking someone, I'll look at him and I do the same thing that he does. It's called mimicry. It's called molecular mimicry. There are some stuff in here, and there are some molecules in the heart which are similar. So these antibodies can also bind to the heart, especially valves, V-A-L-V-E, valves of the heart, and they cause inflammation there. And this is very bad. They can also bind to some stuff in the knees or in the joints, and they cause joint pain. For that reason, it's called rheumatic fever or acute rheumatic fever. Acute rheumatic fever is a type 2 hypersensitivity. It's an unwanted immune response. This part is good. It's against the microbe. But this part is bad. What was the definition of hypersensitivity?
It's unwanted response.
Raise hand, say it in English. Arabic would be good too.
It's unwanted response.
Unwanted immune response or any type of
unwanted response, immune response that causes a joint.
Very good. I would say it more completely like this. Any type of inappropriate, memorize this, inappropriate or exaggerated immune response that causes damage, which is unwanted immune response. Inappropriate or exaggerated. Is this a hypersensitivity? Is this a bad immune response?
Yeah.
Yes, it is a bad immune response. This part is good, but now antibodies are doing something that they shouldn't do. They go and bind to the heart and they cause problem. And this is a type 2 hypersensitivity. It's mediated, it's caused by IgG molecules. And this is very important. So, because I want to mention another disease later, memorize this: acute rheumatic fever. Write it down. Acute rheumatic fever. It's abbreviated as ARF. Acute rheumatic fever. Why rheumatic? Rheumatism means joints, because it can also appear in joints. But the problem with acute rheumatic fever is not joints. Joints will get painful and then it will go away. The problem is with the heart. So a question that I have for you, and I will let you think about it, is that what should I do then? A person has got pharyngitis, bacterial pharyngitis. I know that it will go away. It's a self-limiting disease. But the problem is that antibodies that are produced can damage the heart. How can I solve the problem? What is the solution? Can I tell antibodies not to bind to the heart? They will anyway. How can we solve the problem? Keep that in mind. Let's see what you come up with. So, the last part, can I have antibody responses against my own antigens? Come back to blood again. Sometimes antibodies are produced against the red blood cells, not the drug at the surface of the red blood cell, the red blood cells themselves, and they cause hemolysis, and it will lead to hemolytic anemia. This time, it's called autoimmune hemolytic anemia. The previous one was different. What was the previous one? It was drug-induced hemolytic anemia. That was not autoimmunity, because antibody was against the drug. It was not against my own antigens. But here it's against the red blood cells, and this is a red blood cell that is undergoing lysis. The way that I know it is that it's got smaller and shrunk. Autoimmune hemolytic anemia. This is another example. I don't have a slide for this, so I want you guys to look it up and see what you see. There is a disease named myasthenia gravis. Can you look it up with your cell phones or your laptops? Myasthenia gravis. Myo means muscles. Asthenia means weakness. Gravis means severe. For me to contract my muscles, I need some nerve endings to release acetylcholine. It's a neurotransmitter. And acetylcholine will bind to receptors at the surface of my muscles, and then I can contract. Some people develop antibodies against these receptors. Antibodies bind to receptors for acetylcholine, like these tiny things are acetylcholine. Antibody binds to that, and they inactivate the receptor. So the acetylcholine cannot bind. And what happens? You see a patient like this. He cannot lift his eyelid. It's called ptosis. P-T-O-S-I-S. I remove my glasses, I can't see you now. It's ptosis. Alright? It's one of the first symptoms of myasthenia gravis. Did you see images of myasthenia gravis? Google image search?
Yes.
Can you see that? Good, good. Are you all seeing that myasthenia gravis image search? Are you seeing the falling of the eyelid? Myasthenia gravis? Anybody? Okay. Anything else? Myasthenia gravis. I'm talking, but if muscles not contracting well, you cannot talk anymore. This is called talking problem. Why? Because antibodies are binding to this, and they don't let the muscles in my larynx to work properly. When I came to this class, 2 steps, no problem. Step 1, step 2. If it's myasthenia gravis, things become much more difficult. Why? Because there are antibodies binding to where acetylcholine is supposed to bind. Is this an example of hypersensitivity? What was the definition of hypersensitivity? This time say it correctly. What is the definition of hypersensitivity? People at the back of the class. Any type of inappropriate or exaggerated immune response. Is this an inappropriate immune response? Yes, it is an inappropriate immune response. And it's also an autoimmune problem, because the target is my own receptors. Alright? So we have type 2 hypersensitivity. These are examples. And then here we get to type 3 hypersensitivity. So it's 2 relaxation or a break. So for 10 minutes we will have a break and then let's come back to complete the class. Any questions?
Why antibody binds to the cells that when there is no infection?
No, that's exactly the problem. Antibody is generated against my own antigens.
Why?
That's a mistake. That's a mistake. So why it happens, that's an interesting question. I don't know exactly. But one thing is that the tolerance is broken. I should have and he used that toxin to treat children with diphtheria. It was named anti-serum. So anti-serum was very good. And it's not only for diphtheria. You mean for snakes, for scorpions, for spiders? These all have poisons. If someone has a sting, scorpion sting, or spider sting, or a snake bite, how can you treat the person? With anti-serum. With antibodies against the poison. So Behring generated the first anti-serum for diphtheria, and that was very good. This is different from vaccine, by the way. He did not produce diphtheria vaccine. Vaccine was produced later. Vaccine is sometimes when you inject the body with the microbe or with the toxin, and then my own body starts producing antibody. That is vaccination. The antibody has been produced somewhere else and is injected to the body. Okay, so here's the question. How did Behring generate the anti-serum? For an anti-serum, you have to have a living animal or living human being to generate it. How did he generate the anti-serum? He generated like this, in horses. In horses. He got the toxin, diluted the toxin, and injected horses with it. If you inject too much, they will die. But if you inject tiny bit, they won't die. And they start producing antibody. After a few weeks, you get blood from the horse, and then you centrifuge it and you take the serum. The serum is the upper part of the blood, the fluid part of the blood. And that is anti-serum. It has antibodies against the toxin. And he used that horse anti-serum to treat children. So that part was good. But then something happened. You see, when you get the serum from the horse, it has antibodies, but it has other things too. It has a lot of horse proteins, like horse albumin, horse fibrinogen, which are foreign for our body. So one thing that happened is that when they injected people with the serum, some people started having rashes all over the body, red discolorations. They named it serum sickness, a disease caused by the serum. Why this happened? Because my own body starts producing antibodies against the horse proteins. You see, the serum is from the horse. Serum of the horse has antibodies against the poison, against the scorpion poison, or snake poison, or diphtheria poison, or the toxin. So that part is good. But there are a lot of horse proteins there. My body identifies those proteins as dangerous things, but they are not really dangerous. My body starts producing antibodies against them. And these antibodies will go and bind those horse proteins, and a lot of complex antigen antibody complexes are formed. And these complexes deposit under the skin, and they cause inflammation. It's called serum sickness. Serum sickness. This is another example of it. For this reason, nowadays people usually don't use horses. Some places still do that. But it's better if you can produce anti-serum in human beings, or with other methods, like new engineering or antibody engineering methods, so that you don't have to inject a lot of horse protein to the patient's body. So this is serum sickness. Serum sickness sometimes happens, this is type 3 hypersensitivity, because immune complexes deposit in the skin and you get inflammation. We have another type 3 hypersensitivity, which is named after a British scientist named Artus. It's Artus reaction. And Artus reaction is very interesting. You know, tetanus vaccination, every 10 years you need to get tetanus vaccination. So when I get tetanus vaccination at the age of 35, I don't have a lot of antibodies from my previous vaccination in my body. Like I've had one injection at the age of 15, and then I get to 25. Nothing happens. Some people, however, when they get the vaccine under the skin, they still have some antibodies from previous vaccination. And those antibodies come and bind to these antigens because vaccines are basically antigens. And they generate a lot of immune complexes under the skin. And they cause inflammation in here. So this is similar to the serum sickness, but serum sickness was all over the body because serum is injected intravenously. But this happens locally after I get a vaccine for which I still have antibodies from previous vaccination. So if I want to say type 3 reactions against harmless antigens, sometimes it's systemic, it's all over the body. And the example for it is serum sickness, anti-serum, horse anti-serum especially. But sometimes it can also be local, like in the part of body that something is injected. It's called Arthur's reaction. This is systemic and this is local. This is systemic immune complex formation all over the body. This is local. In one region you have these things. Can you have hypersensitivity against a microbe? Type 3 hypersensitivity. This is a skin infection. Again, by streptococci. Streptococci can infect the throat. They can also infect the skin. The name for this is impetigo. Could you look up the word impetigo? I-M-P, impetigo. I-M-P-E-T-I-G-O. Impetigo. People at the back of the class. Did you find it? I'm going to come there and check. Okay. I-M-P, impetigo. I-M-P-E-T-I-G-O. Impetigo. And do image search. Do image search. Impetigo. You're all seeing it?
Yeah.
Impetigo. Show me impetigo. No? No? Impetigo. Good. Excellent. Good. Show your friends too. Impetigo. Impetigo is a skin infection by streptococci. So now search another word. I should stay here, otherwise we like there wasn't me. Now search another word in Google. The word is hematuria. What is hematuria? H-E-M, 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 A-T-U-R-I-A. Hematuria. It's written hematuria. H-E-M, A-T-U-R-A-U-R-I-A. Hematuria. What is hematuria? Blood in the urine. Blood in the urine. Okay, so what is the relation? Very good, very good. Hematuria, hematuria. Hematuria. Good. Image search, image search, image search, image search. Okay, what is the Arabic for hematuria? Say it loud. Okay, al-bawl damawi. Okay, it means dam is present in bowl. Okay, hematuria. So sometimes people who have this, after a few weeks, they get hematuria. Why? Hematuria means kidneys are damaged. Why? This is a skin problem. Why should impetigo lead to kidney problem? The reason is this. These microbes in here produce antigens. Their antigens go to the blood and they go to the kidneys. This is a glomerulus. Glomeruli in the kidneys, glomerulus. So glomerulus, this yellow stuff are epithelial cells, and then this green stuff are some other epithelial cells, and there is a basement membrane here. So the antigens come and get stuck in here between the basement membrane and the epithelium. Then antibodies attack. Antibodies attack and form immune complexes here under this sorry, this is an endothelium, this is epithelium. Under the endothelium, and then some other cells would come, neutrophils would come, because neutrophils want to phagocytose antigen-antibody complexes. Neutrophils would get stuck there as well. They cause inflammation. Nephritis, what is the meaning of nephritis? Arabic word for nephritis. Come on, fast. Don't have time.
Inflammation in the nephron?
Yeah.
Inflammation in the nephron?
Yeah.
Yes, but that's the English word. What is the Arabic word?
التهابات كبيبات الكلى.
التهابات. Okay, good. I didn't get the second part, so I'll get to stick with that. So nephritis, glomerulonephritis means inflammation in the kidney in the glomeruli. This happens after a streptococcal infection. Is this a good immune response or a bad immune response? It's a bad immune. What was the definition of hypersensitivity?
It's unwanted.
Say it completely this time. I'm repeating this.
It's unwanted.
Unwanted immune response, inappropriate or exaggerated immune response. This is an inappropriate immune response. But it's an inappropriate immune response against the microbe. But it's damaging our tissues. It's called, write this down, PSGN. PSGN. PSGN stands for post-streptococcal glomerulonephritis. It's a long name. So if you want to brag about being medical student, you know bragging? What is bragging? Search bragging, B-R-A-G. If you want to brag, bragging, what is bragging? B-R-A-G. You say, yeah, that guy brags a lot. He brags about being a medical student. What is it? Tafakhur, exactly. If you want to brag about being medical student and knowing a lot, this is one thing that you can say fast and loud. Can you repeat it 3 times? Raise hands. Who can repeat it 3 times? Guys in here, come on. Can you say post-streptococcal glomerulonephritis 3 times? Come on. Yes. Yeah, go ahead. You don't want to brag about being a medical student, can you say? In the previous class, one of the ladies did. Guys couldn't.
Say it again.
Say it again. Read it from there. Post-streptococcal glomerulonephritis. Say it 3 times. No, that's not going to work. You need to raise your hand and say it loud.
Could you say that?
Post-streptococcal glomerulonephritis.
Can you speak rapidly or slowly?
Slowly, do it slowly. Quiet, okay, go.
Post.
No, not that slow,
Post. Osteococcolia.
Fail, no. You go ahead. Say it 3 times. No, post-streptococcal. Okay. 1. No, the last time was not good. Yeah, go ahead.
Post-streptococcal granulonephritis.
What?
Post-streptococcal granulonephritis. Post-streptococcal
Okay, good. Okay. Say it. Applause for all of you, but try to learn PSGN, post-streptococcal glomerulonephritis. So this is a type 3 sort of hypersensitivity. Can it be autoimmunity? Can it happen against our own antigens? Yes. A famous or infamous actually autoimmune disease is systemic lupus erythematosus. Can you say it 3 times? Okay, SLE. Antibodies will be generated against our own antigens. Complexes will be formed. And these complexes can deposit all over the body, including kidneys, skin, lungs, heart, and the rest of the parts. This is an autoimmune disease. This one was not an autoimmune disease. The target is bacterial antigen. The tissues are damaged, but the target is bacterial antigen, so it's not autoimmunity. But this is an autoimmunity. It's our own antigens. And lastly, type 4 hypersensitivity. This one is caused by T lymphocytes. The previous one was antibodies. This can be here against harmless things, can be here. Autoimmune problem can be here. Infectious agents. Can it be against harmless antigens? Well, we all eat bread, bread.
Yes.
Bread is made from wheat, W-H-E-A-T. Wheat has gluten in it, it's a protein.
And Arabic would say حساسية حنطة.
حساسية
حنطة.
Unta. Okay, so the wheat in Arabic is
Yes.
Very good. So the disease is also named celiac disease. Why? I eat gluten and I'm fine. Some people, their T cells see the gluten and say, oh yeah, you're a bad guy. But it's not a bad guy. They start proliferating. Where do they proliferate? In my intestinal mucosa. And they destroy the villi. These are villi. We require them for correct absorption of fluid and stuff. They remove the villi. It's called celiac disease. You see a child which is having diarrhea all the time. This diarrhea stops if you stop eating bread. Or if you start eating bread which is made from maize. Maize, M-A-I-Z-E. Could you look it up? Bread from maize, M-A-I-Z-E. M-A-I-Z-E. Exactly. Can you make bread from maize, from durra? Sure. It's not very tasty, but you can do it. If you eat gluten, you will have problem. If you don't eat gluten, you're okay. It's called celiac disease. Yes.
You can't eat bread from rice.
Sure, I think you can eat bread from rice as well. Anything other than wheat. Yes. But rice is expensive, so they will go for that. But that's great. Is this a hypersensitivity? Is this a good immune response?
No.
This is a bad immune response. T cells are active against something that they should not be active against. That's a problem. How about this one? This is more relevant for ladies. So sometimes people wear earrings or bracelets and they start having dermatitis. It's called contact dermatitis. You know the earrings or the jewelry? Part of it they have gold and silver, so that part is usually fine. But there are other metals as well, like nickel, N-I-C-K-E-L. So the nickel is absorbed to the skin and it binds some proteins and then T cells come and see it as something dangerous. It's not really dangerous. They start proliferating in here and they cause inflammation. It's called contact dermatitis. This is another example of type 4 hypersensitivity. Can it happen against microbes?
Yes.
Sure. The disease is named tuberculosis. You know tuberculosis is an infectious disease. It's caused by Mycobacterium tuberculosis. So if Mycobacterium enters my lung, immune response is necessary. We need immune response to fight off Mycobacterium. But sometimes the immune response becomes exaggerated. You get too much of it. And the immune response destroys the lung. So there are two things. Mycobacterium destroys a little bit, and then immune response destroys even more. This is an immune response against the microbe which has become too strong. It's causing damage. That is why in a TB person, in a person with a tuberculosis, if he's almost okay without severe lung problem, you use antibiotics to fight off the bacteria. But there are some cases of tuberculosis that the inflammation in lung is too strong and the person is dying. In those cases, you start antibiotics, but you also give the patient corticosteroids. Corticosteroids. What do corticosteroids do? They reduce inflammation. They reduce immune response. Why should I reduce immune response if there is a micro? Immune response is necessary. Well, because there is too much immune response and it's causing damage. And this is immune response is mostly caused by T lymphocytes. So it's an example of type 4 hypersensitivity. We use this process in tuberculin test. When you have someone that you want to see whether the person has been exposed to Mycobacterium tuberculosis, you inject the person with a little bit of mycobacterial antigens, and then you wait for 48 to 72 hours. If the person has been previously exposed, T cells would appear here. And then you see the area is kind of hardened. The area is kind of hardened. One thing that I need to mention in here is that this type of hypersensitivity, it has another name as well. It's called DTH. D for delayed, T for type, H for hypersensitivity. DTH. What is DTH? It's a hypersensitivity that takes time to appear. This is in contrast to type 1 hypersensitivity. That was immediate type hypersensitivity. In the prick test with the allergens, 20 minutes you get the result. Or you get exposed to the allergen almost half an hour after that, your nose starts running, you get problem with breathing, bronchial asthma, you get anaphylactic shock. But this one, 2 to 3 days you require. That is why that one is immediate. This one is delayed type. So if you hear DTH, it means type 4 hypersensitivity. And finally in here, can we have DTH against my own antigens? Here? Yes. A lot of bad autoimmune diseases are caused by type 4 hypersensitivity. This disease is named rheumatoid arthritis. Inflammation in the joints, especially small joints of the fingers, because T cells appear in here and destroy the joint. We had another disease that people sometimes mix up. The previous one that was caused by streptococcal infection of the throat, that was acute rheumatic fever, ARF. ARF is not an autoimmune disease. This could be the question for your exam, by the way. Learn it. ARF, acute rheumatic fever, is not an autoimmune disease. The streptococci infect the throat, antibodies are produced and they damage the heart. That was a type 2 hypersensitivity. This one is called rheumatoid arthritis, RA. ARF is different from RA. This is an autoimmune disease. That one, ARF, was not an autoimmune disease. ARF was type 2 hypersensitivity. This is type 4 hypersensitivity. It's made by T cells. Okay? What else? Multiple sclerosis. This is another autoimmune disease, which is also type 4. Myelin covers nerves. T cells destroy myelin. Multiple sclerosis. And it can happen in brain or spinal cord, and then you might have problem seeing or problem walking because myelin has been damaged. And finally, the famous diabetes type 1. This is pancreas. These are Langerhans islands. So these blue cells are beta cells. Beta cells produce insulin. T cells go there and destroy the beta cells. And the person develops diabetes. This is an autoimmune disease, which is caused by type 4 hypersensitivity. All right. So end of the class. Here is the summary slide. I have written things small because, well, there was not enough space. Type 1 hypersensitivity is here. Allergy to food, to penicillin, to bee venom, to drugs. Another name for this is immediate type hypersensitivity. It happens fast. Here, we don't have type 1. It's only there. Type 2 is here. Type 2 is here. Can be against harmless things, like a drug. But the drug, if it's bound to the surface of the red blood cell, it can kill the red blood cell, causing hemolysis. it can happen up in here. AIHA, because I didn't have enough space to write in here. It's autoimmune hemolytic anemia. This is hemolytic anemia. That is hemolytic anemia. This one is caused by a drug. It's not autoimmune. This one is autoimmune. What is the difference? Here the target is the drug. Here the target is the red blood cell itself. But both of them are type 2 hypersensitivity. We can also have type 2 hypersensitivity against infectious agents. What was the example? Streptococci in the throat, antibodies produced against them, damaging the heart. Alright, the target is a microbe, but damage happens to the heart. How about type 3? How about type 3? Can we have type 3 against the harmless thing? Can we have type 3 against the harmless thing? Yes, against horse proteins. Why should I care about horse proteins? I don't eat horses. Well, in the past some people have eaten horses, but today we don't eat horses. Why should we care? Because horse proteins are present in anti-sera that we receive. And then antigen-antibody complexes can form, and then I get rashes all over my body. This is not autoimmunity. The target is horse protein, not my own proteins. But here we have type 3 autoimmunity. SLE, it's against my own antigens, and then you have deposits of antigen-antibody complexes, especially in the kidneys. And this one, it can be against an infectious agent. Could you say what PSGN stands for? And then say it 3 times. What does PSGN stand for? Come on, you need to brag about being a medical student. You guys are very humble people, and you want to be very nice and don't say words that other people don't know. So, but I won't let you guys leave this class before you say PSGN 3 times. What was PSGN? Post? Streptococcal glomerulonephritis. All right. Type 3 hypersensitivity. And finally, type 4. Type 4 can be against harmless things like gluten in wheat or earrings. Can be against our own antigens. Rheumatoid arthritis. Don't mix this RA with acute rheumatic fever. This is the most common mistake I see in medical students. This is one thing, this is not autoimmune. ARF damages the heart mostly. This is rheumatoid arthritis, it's an autoimmune disease. Multiple sclerosis, what is T1D? 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 Type 1 diabetes. Alright? And finally, here tuberculosis, in which you have hypersensitivity type 4. Done. End of the class. So it's almost 3 o'clock. I think we can start the next class in 15 minutes. 15 minutes is good. Well, you need to read references to the exam. There are exam vehicles in the exam. So you need to read the book. What are the exam usually decides? My class, yes, the other professors are here. immune system, and if any part of these collections in here are damaged, we would be having immunodeficiency. So we're going to start with primary immunodeficiencies, which are caused by genetic problems. And at the end of the class, I'll tell you about HIV and AIDS briefly as well. So again, we have innate immune system and adaptive immune system. We have barriers, we have phagocytes, we have B cells and T cells in here. And then based on where this immune system structure is perturbed, we have different types of primary immunodeficiencies. So this is the categorization of primary immunodeficiencies. Sometimes the problem is with T cells. It's called T cell deficiency. Sometimes the problem is with B cells. It's called B cell problem, B cell disease. Sometimes T cells and B cells are deficient together. These are called combined immunodeficiencies. Combined, it means that those T cells and B cells are damaged. And sometimes the problem is with phagocytes or with complement, which is also a part of innate immune system. So for that reason, this is the classification. Pure T cell problem, only T cells are damaged. Pure B cell problem, only B cells are damaged. Combined immunodeficiency, combined means B cell plus T cell. Phagocyte problems and complement problems. So before going into each of these categories, I'm going to show you a table which sort of gives us the general features of these immunodeficiencies. If T cells have a problem, either T cells alone or together with B cells, the disease starts very early. The first couple of weeks after the birth, problems start. What problems? Infections. Immune system defends us against infections. So if I have T cell problem, either alone or together with B cells, infections start. What kind of infections? Infections which are called opportunistic infections. Opportunistic infections are infections that usually don't happen in normal, healthy people. And I will show you examples of them. And they start right after birth. First week, second week after birth, you have problems. If the problem is with B cells alone, so if the problem is with T cells, either T cells alone or together with B cells, it starts very early. And then we have the so-called opportunistic infections. We'll see them. What if we only have antibody problem, B cell problem? It usually takes some time for the infections to appear. They don't appear right after birth. Why is it so? Why is that if I have problem with T cells, it starts in the first few weeks after birth. But if it's a B cell problem, I'm protected for a few months. Why? Because I still have my maternal antibodies. Antibodies are transferred from mother to fetus during pregnancy, and those antibodies remain in the blood for a few months after birth. Especially IgG remains at protective levels until the third or fourth months of age. After that, there are no maternal antibodies anymore. And if I have B cell problem, I cannot produce my own antibodies, and the infections start to appear. What kind of infections? Usually mucosal infections. Sinusitis, pharyngitis, pulmonary infections, and gastrointestinal infections. These are called sinopulmonary, sinus, pulmonary, and GI infections. So this is one major contrasting feature between these two types. If it's T cell, it starts fast because T cells are not transferred from mother to fetus. When I'm born, I don't have any of my mother's T cells. But when I'm born, I have a lot of my So if I have problem, T cell problem shows up fast. But if it's a B cell problem, it doesn't show fast. Until 3-4 months, when the maternal antibodies disappear, we have the problems. Phagocyte deficiencies usually appear before the age of 5 and usually pyogenic infections. It's called deep tissue infections. Like pharyngitis is not a deep tissue infection. Dermatitis infections is not a deep tissue infection. But if it goes to my bones, osteomyelitis, if it goes inside my joints, arthritis, pyogenic arthritis, if it goes deep inside my soft tissue, it's called abscess. These are called deep tissue infections. And they appear when you have phagocyte problem. How about complement? Well, it depends on which part of the complement is defective, but the main type of bacteria which infect us during complement deficiencies are bacteria that have a capsule, like Neisseria, for example. So memorize this table. You will have at least one question from this table. T cell problem appears fast, B cell problem 3 to 4 months of age, and phagocyte problem usually later but before the age of 5. This one, opportunistic infections that don't usually appear in normal people. This one, sinus, lung, GI infections. This one, deep infections. And then for complement, the story is a bit different. So let's start from the worst case.
Why we call them deep? Why we call them deep?
Deep because a lot of infections that we have are superficial infections. Like one kind of infection which is very common is common cold or bacterial pharyngitis. Where is it? It's my throat. It's at the surface of mucosa. Sinusitis, sinuses in here. They are surface of mucosa. Gastritis, enteritis, these are all mucosal infections. But osteomyelitis, it's inside the bones. It's different. It's not the surface anymore. Arthritis inside the joint, or abscess. Abscess is a collection of pus, P-U-S, pus. What is the Arabic word for pus? Tell me. P-U-S, what is the Arabic word for that? Help me learn something. P-U-S. And what is the Arabic word for abscess, by the way? P-U-S, what is the Arabic word for pus? What? Pus? Okay. How about abscess? Abscess. A-B-S-C-E-S-S. What is the Arabic word for abscess? Forage? Could you show me? Okay, very good. Okay. So these are examples of deep tissue infections. They are not skin, they are not mucosa, they are inside the tissues. So let me start from combined deficiency. Combined deficiency means T cell has problem, B cell has problem at the same time. That is why it's called combined. So these are T cells and B cells. When T cells and B cells are developing, they generate antibodies or receptors at their surface. The surface of the B cell is called B cell receptor. It's basically the same as antibody molecules. And then we have T cell receptor at the surface of T cells. So B cells and T cells have a developmental process that you've seen in previous classes. This is a mature B cell, this is a mature T cell. Before that, it's immature B cell, pre-B cell, and pro-B cell. This happens in thymus. Thymus is in here. Well, probably my thymus is too small now because it decreases in size after puberty. This happens in bone marrow. Bone marrow is the university for B cells. Thymus is the university for T cells. So sometimes they have genetic problems that blocks this process. There is an enzyme named RAD, which is a very important enzyme in generating the receptors for these cells. If there is mutation in here, you can't go past this step. And you won't have mature B cells and mature T cells. And it can lead to what is called you type SCID in your laptops? SCID. It's pronounced skid. SCID. What does it stand for? Say it loud, say it loud. Back of the class, SCID. What does it stand for?
العوز المناعي المشترك.
Good. Very good. Severe combined immunodeficiency. It means both T cells and B cells are involved. One is because we have problem in the rags. The other one, tomorrow I will tell you about this in more detail. This is the way that antigen presenting cells show antigen to T cells, sometimes become T helper 1, 2, or other types. So T lymphocytes, if they want to act correctly, they need a cytokine named interleukin 2. Interleukin 2 is necessary for T cell activation, and T cell activation is necessary for B cell function. Another possibility is that you might have a genetic problem in the receptor for interleukin 2. This can cause problem for T cell activation and as a consequence for B cell activation. There are two more problems in here too. These cells need to proliferate. The proliferation is named mitosis. For mitosis, you need your DNA to replicate. DNA needs to increase. And for DNA to replicate, you require nucleotides. They are called DNTPs, like the oxyadenine triphosphate, the oxycytosine triphosphate, the oxyguanine triphosphate, and the oxythymine triphosphate. If you have problem in making these things, again T cells cannot proliferate, and as a consequence B cells cannot function very well, and then again you have a skip. And finally, if this molecule is deficient, which is the MHC molecule, again T cells cannot be activated, and as a consequence B cells would have problems, and you have T cell together with B cell problem. So we have different types of skid. Severe, say the Arabic one. Say it loud. You forgot, come on. Say it again. No, the Arabic expression.
العوز المناعي المشترك. العوز المناعي المشترك.
Very good. Okay. So sometimes the problem is with the RAG genes. Sometimes IL-2 receptor has a problem. Sometimes the NTPs are not produced, and sometimes MHC has a problem. This one is the most common form. This could be a question for the exam. What is the most common form of severe combined immunodeficiency? Problem in interleukin 2 receptor. This one is the second form, which is common. All right. So we have, say, let me summarize. Different genetic problems can lead to skid. The most common is problem with receptor for interleukin 2. The second common is the problem for mitosis because of the lack of DNTPs. So what happens in these people? You look at their blood and there are no T cells or very limited number. There are no B cells or very limited number. If T cells are not there, if you add mitogens which stimulate T cells, you don't see anything. T cell proliferation, you don't see because there are no T cells. You don't see antibodies there. It's called hypogammaglobulinemia. It's a long name. Can you say it? Say it, otherwise you're going to have to repeat PSGN again. Hypogammaglobulinemia. It means IgA is not there, IgG is not there, IgM is not there. Good, you're getting there. Come on, you're getting there. And also, if you vaccinate the person, you don't see an antibody response. So no T cell, no B cell, no mitogen response, no antibody. It's very bad. It's very bad. What happens to the person? Severe infections after birth, like varicella infection, chickenpox, varicella, my God, what is the chicken pox? Varicella. Chicken pox. So your Arabic is not good, not very good, like my Arabic.
Yeah, الجدري.
Chicken pox?
الجدري.
جدر
جدري مائي. جدري مائي.
جدر مائي.
Yes, جدري الماء.
Okay, chicken pox. So chicken pox, we've all got chicken pox. Problem. And it goes away. It's self-limiting disease. But here in the skin, it doesn't go away. It becomes very severe. All right? Progressive varicella all over the body. So the only solution for this problem is a bone marrow transplant. You need to give new bone marrow cells to the person who has this kid so that he or she can have new B cells and T cells. That is the only solution. And if you have a skid and you can't get a bone marrow transplant, you cannot live, you cannot survive. If you want to survive, you have to be kept in a sterile environment. So this is the story of a boy with a skid, born almost many years ago, 1972, named David Witt. He was born with a skid, and there was no suitable bone marrow donor. You need to get bone marrow cells from a donor, the person, and then give it to the recipient, but they need to be genetically very similar. So he didn't have a good donor, so his parents decided to keep him in a sterile environment, inside like a bubble. Everything inside had to be sterilized. Food had to be sterilized. Water had to be sterilized. Clothes had to be sterilized. And the boy had to live inside this bubble, the sterile bubble. And you can imagine how difficult that would be. Even if you want to change the clothes, there are some glove compartments in here that you had to put your hands in so that you cannot touch the person. Change the clothes and then take out the clothes through an opening and put in the clothes which are sterilized and then go through this and put it on.
But why?
Huh?
Why in the bubble?
Because if you come out, you'll die. There are a lot of microbes around us. If you get exposed to area outside in a sterile environment, you'll get severe disease and die. This is the case for skid people. They're very sensitive. You see? It's like this. So because he was kind of famous in American media, NASA made him a suit like astronaut suit, so that he can wear that and come out of that sterile environment. And he was 8 or 9 years old. For the first time, he could walk out of that suit. So the air going inside had to be sterilized. Everything inside had to be sterilized. And this was the way that he could come out. So you see how important it is to have a functioning immune system. Like you get up in the morning, you go eat breakfast, you get on a car or a bus, you come here, you talk to your friends, you go to the canteen to eat food, you go to do your prayer in the mosque, come back to the class, you shake hands with your friends, you go to the cinema, everything. And you're exposed to microbes all the time, no problem. Your immune system takes care of that. But if you have B cell and T cell problem, all those things are basically impossible. All those things are impossible. So this is what happens for a skid person. So when he was 13 or 12 years old, his parents decided to give him a bone marrow transplant from a donor which was not the best, but that was the only option that they had. Unfortunately, that donor had a dormant EBV infection. Dormant, D-O-R-M-A-N-T. What is dormant? Dormant in Arabic. D-O-R-M-A-N-T. Dormant infection. D-O-R-M-A-N-T. What's the Arabic for dormant? Inactive. Dormant. Inactive infection.
Comet, we say.
What?
Comet.
Hamid?
Oh, comet.
Very good. infection got activated and he died after a few days. So this is a sad ending to a sad story, but it also tells us how important it is to have a functioning immune system. Otherwise, you have to live inside a bubble. We all have to live inside bubbles, which was basically impossible, very difficult. All right. So this is called severe combined immunodeficiency. Severe combined immunodeficiency. Sometimes B cells are okay, but we have T cell problem. We have a disease named Dye-George syndrome. It's another genetic disease in which molecules inside T cells have problems. And people with Dye-George disease have a problem in chromosome 22. They have heart problem, they have parathyroid problem, and they have thymus problem. If you don't have thymus, T cells will not be there. If there is no medical university, there would be no doctors. If there is no thymus, there would be no T cells. So these children have T cell problem. Usually their faces are a little different. They have a big forehead. Sometimes their eyes are a bit separate. And sometimes they have other facial features that you're seeing in here. And sometimes they have the so-called cleft palates or cleft lip. The lips are separated. And the palates, it has a cleft inside. So these people have Dye-George syndrome, and it's a T cell problem, which is a difficult disease. It's not as bad as the SCID because they have B lymphocytes, but they have T cell problems and they get a lot of infections. So B cell immunodeficiencies, we have a lot of them. I'm going to tell you about the first two ones. In the first one, we have B cells, but they cannot be activated. It's called CVID, common variable immunodeficiency. In the second one, we don't have B cells at all. That's the take-home message. The first one, B cells are there, but they cannot be activated. They don't produce sufficient levels of antibodies, CVID. But in the second one, which happens only in boys because the gene for it is present on the X chromosome, so girls don't get it usually, boys get it, you don't have B lymphocytes. So let's look at CVID first and then the second one. This is a B lymphocyte. When antigens bind to it, they send a message to the nucleus telling it needs to proliferate. So it starts proliferating. It's called mitosis, proliferates. And then they start producing antibody. That's what happens in the ordinary people. But people who have CVID, if you look at this antibody, that antigen has bound, in order for this to get activated, there are some molecules that help in the process. If you have mutations in these molecules, then you will have decreased B cell activation. There are several molecules, I don't want you to memorize their names, but just keep in mind that B cells are there. These molecules have a problem. They see the antigen, but they don't do anything. And because it's more common than other B cell problems, it has the word common because it has variable forms. It's called common variable immunodeficiency. What is the problem in these people? They have low levels of immunoglobulins. It's called hypogammaglobulinemia. Can you say? If you don't have it, it's called agammaglobulinemia. Agammaglobulinemia, person doesn't have anything. But if it's low, it's hypogammaglobulinemia. So hypo, if you have problem with IgM and IgG and IgA, three main classes, it's called pan-hypoglobulinemia. What is pan? Like, say, pan-American. It's all American. Pan-Arabism. It's everything should be Arabic. Pan-Turkism. Everything should be Turkic. Pan means all, everything. Pan-hypo, it means that all of them are low. Pan-hypo, all of them are low. What is low? Gammaglobulins. And IA means the situation. So it's pan-hypogammaglobulinemia. So if it's difficult, say just pan-hypo. Okay, pan-hypo is okay? Okay. Pan-hypogammaglobulinemia. Why? Because T cells are not activated, so we don't have sufficient antibodies. And then this leads to some other problems. Problems that happen are like this. If you don't have sufficient antibodies, you get a lot of superficial infections. You see, deep infections, superficial infections. Deep infections inside the bone, abscess inside the tissues, those are deep infections. But here, skin infection, GI infection, mucosal infection, respiratory infection, pharyngitis, infection in the lungs, and sometimes other organs. So you have low levels of antibodies, and you get a lot of infections. The issue in here is that T cells are okay, and B cells, if you look at them, they also seem okay. But the problem is that they don't get activated. So cells look okay, but they don't get activated. So you have low levels of these things, you have these problems, but T cells and B cells are, when you look at them, they look okay. So this is called CVID. What happens? The skin infections. This is a child with CVID, skin infection. This is infection in the intestinal tract, and a lot of big lymphoid tissues there because, well, other T cells are trying to recompensate. Giardiasis in a patient with CVID, well, it's not seen from endoscopy, but you can see it in the laboratory. And if it takes too long, repeated lung infections, there is a situation called bronchiectasis. Bronchiectasis means bronchi are getting too large because the valves in between them are destroyed, so you see things like this in the lung. You will hear this later when you do your physiopathology, pathophysiology, and externship. So lung problem, skin problem, GI problem, superficial infections. We have another disease named Bruton syndrome, or X-linked agammaglobulinemia. There it was hypogammaglobulinemia. It was low. Here it's almost absent. And this is relatively easy to pronounce because Bruton is easy to pronounce. The other way to say it is XLA. So it's relatively easy. XLA, X-linked agammaglobulinemia. This is a problem for B cell development. The previous one, B cells were looking okay, but they could not be activated. Here you don't have B cells at all. B cells are not there. B cells are not there. Why? Because there is an enzyme named BTK which has a problem, and then you don't have any B cells. If you don't have B cells, you don't have antibodies. It's called agammaglobulinemia. That was hypo, it's lower, but you still have a little bit. Agamma, you don't have anything. Again, infections, superficial infections, the skin infections, respiratory infections. And the only way that you can treat these guys is to give them immunoglobulins intravenously. It's called IVIG, intravenous immunoglobulins every 3 to 4 weeks. The skin infection in a boy with XLA, deep skin infection, which is relatively severe. Lung infection, again, and you probably need some more time to learn about reading X-ray, but this is a very dilated bronchus, which is due to destruction of bronchial walls. All right. Yes.
The BTK is related to which disease?
BTK is this one, XLA. XLA. BTK, B comes from the name of the British scientist after him the disease was BTK. Alright, I know that you guys are tired, so I'm going to go a bit faster. For the exam, it's okay if you look at the slides, I guess. But try to look at the textbook to learn a bit better. For phagocyte disease, I want to tell you briefly about 2 diseases. One of them is named CGD, and the other one is named after 2 Japanese scientists. What is CGD? Well, when this green thing is a macrophage, and it has engulfed the bacteria, all right? It has engulfed the bacteria. It's eating the bacteria. One way to keep the bacteria, to kill the bacteria, is production of superoxide. Superoxide. Superoxide is an O2 molecule with one extra electron on it, and it can kill the bacteria. Tomorrow we'll hear about that in more detail. And in order for this to be produced, we need an enzymatic complex in here, which is named NADPH oxidase complex. If there is a genetic problem in here, superoxide is not produced. You do phagocytose the bacterium, but a lot of times you cannot kill it. Phagocytosis is okay, but killing is not okay. And then those bacteria remain there and cause different problems. Like this is an example of a skin infection in a patient who has CGD, killing problem. They remain there, and then T cells come to help, and they generate something which is named granuloma. CGD is problem with the production of superoxide. Also, skin infection in a child with CGD. Sometimes it can be very severe and destroy the tissues, like in this case with the nose being destroyed. And finally, there is a disease that was discovered by two Japanese scientists, Chetyak and Higashi. So the story is that if you look at the cell, vesicles in the cell move on microtubules, like a country with a railroad, and then there are a lot of trains that are carrying cargo around. So they have this sort of walking proteins that move the cargo along the microtubules. So what happens in these cases is that microtubules cannot move easily. Sorry, vesicles cannot move easily. One of the things which happen in these people is albinism. They become very white. Because for the skin or for the hair to have its color, you need granules, you need pigments named melanin. And melanin is packed into vesicles named melanosome. And melanosome needs to move to generate the coloring of the skin or the hair. If you have problem in the movement of vesicles, the result could be discoloration, lack of color in the hair or skin. Sometimes people are not completely white. They have this sort of silvery hair. You see, the hair is not completely white, it's like silver, it's gray type. And at the same time, you have infections. Why? Because phagocytes eat the microbe, but lysosomes cannot bond to the phagosome because lysosomes need to move on these microtubules. They cannot bind, and the microbe doesn't die. It's called Chetyak Higashi. And then you have abnormalities in these vesicles, very big vesicles inside the neutrophils and stuff like that. So the name for this is a long name. I have written the name here. It's called CHS, Chetyak Higashi syndrome, CHS, in which vesicle transport is problematic. So complement, different parts of it can have different problems. So complement set of proteins that protect us against different infections. You can have pyogenic infections, but the more important one is the Neisseria infections. Neisseria infections can also happen in complement problems. Okay, so I need to talk about HIV. Do you need a break?
No, continue.
Yes or no?
Yes.
How many yes? How many no? Alright, so I'll finish it in 10 minutes. Is it good? Okay. Yes, very yes. Okay. Finish it in 5 minutes if you can. 10 minutes is too long. Okay, so HIV started with homosexual men. Up to here, the previous ones, they were named genetic immunodeficiencies or primary immunodeficiencies. It means that due to problems with the genes, I had the problem. These ones are secondary immunodeficiencies. It happens during life. They are also called acquired immunodeficiencies, something from the environment destroys my immune system. And HIV/AIDS is the prime example for that. In 1981, a group of homosexual men, and some of them, actually some other people who were not homosexual, but they were IV heroin abusers, they were injecting themselves with heroin, developed a lung problem called a type of pneumonia. Pneumonia is lung infection. They went to a clinic in New York and they checked their lungs and they saw something very strange. They had a pneumonia caused by a particular fungus named pneumocystis. Pneumocystis pneumonia. Why was it surprising? Because before 1981, pneumonia caused by pneumocystis was never seen in adult people. It was only seen in children with genetic T-cell problems, primary immune deficiency. This was the first time that some adults in 30s, 40s had shown up with pneumocystis pneumonia. So they recognized that these guys have an immunodeficiency, but it's not a genetic immunodeficiency because they were 30 years old, 40 years old. If it was genetic, it should have appeared in early childhood. But these guys are okay up to that time. So they recognized that there is something that has attacked their T cells. And now they are showing a disease which is caused by T-cell problem. This was an acquired disease. They named it acquired immunodeficiency syndrome. And it was, the word was made AIDS, AIDS, acquired immunodeficiency. How was it happening? They recognized that there is a virus. This virus can attack leukocytes, including macrophages, through a molecule which is named CD4. CD4 is present on T cells, but it's also present on monocytes and macrophages. So it goes inside the cell. In addition to CD4, it requires a second receptor which is named co-receptor. It goes inside the cell. It has an RNA molecule inside it. The RNA is converted to DNA. Usually DNA is converted to RNA. But this was opposite to that. For that reason, these viruses were named retroviruses. Retro means going backwards. Retro means going backwards. Most viruses make RNA from their DNA. These guys make DNA from their RNA. This DNA goes inside the nucleus and gets itself inserted in the genome, and then RNA is produced and new viruses are generated. This is the life cycle of the HIV. So when it infects macrophages, macrophages don't die. But when it infects lymphocytes, lymphocytes die. What is the difference between the two? Between lymphocytes and macrophages? Not much difference. The only difference is with this so-called co-receptor. Other things are fine. These are CD4 T cells. And when they get infected with HIV, after some time they die. If CD4 T cells die, that's a very bad event for the immune system because these are helper T cells. And they help a lot of functions to take place. So what happens in the beginning is that in the beginning when the person gets the HIV, this line in here shows the virus, the frequency of the virus. It's called primary infection. The person doesn't have a lot of symptoms. It's sometimes like influenza, a little bit of fever, a little bit of body pain, and then it goes away. HIV goes up and it kills a lot of CD4 T cells. This line is the CD4 line. After some time, some antibodies and some other cells control HIV proliferation, so it goes down, and then CD4s go up a little bit. The person enters a stage of disease in which the disease is latent. It's called a latent phase. So the HIV is present in lymph nodes or little by little. And the number of T cells goes down little by little. This phase can take 1 to 15 years. In 80s, when antiretroviral drugs were not available, it could be 1 year or less. Now with new drugs, it can last many, many more years. In this stage, person is HIV positive, but does not have AIDS. HIV is there, but AIDS has not yet happened. When does AIDS happen? When the number of CD4 T cells goes beyond 200 per cubic millimeter. Usually we have more than 1,000 CD4 T cells in microliter or cubic millimeter of blood. When a lot of them die and it goes below 200, then problems start. And now this is called AIDS. What kind of problems? Infections. Infections start. What kind of infections? Infections like this. Candida infection happens in normal people, very limited, very basically mild way. But HIV positive people that have decreased CD4 T cells can have severe Candida infection. It can even go all the way down, basically affects all of the tongue and esophagus. Candida esophagitis can happen in them. Other infections can also happen. Toxoplasma is a parasite that usually doesn't infect ordinary people, but in these cases it can have severe infections in the central nervous system. This is severe herpes infection. You see herpes infection that sometimes we get on our lips and it goes away after some time. What is the Arabic for herpes? Teach me this one too. What is the Arabic for herpes? Herpes infection. It's very common, especially when the person is under stress. Herpes infection can happen on the lips. H-E-R-P-E-S. H-E-R-P-E-S. P-E-S. H-E-R, herpes. P-E-S. Herpes infection of the lips. Just herpes? Just herpes? Okay.
هذا المنطقة.
داء المنطقة. Okay. So it happens on the lips, but it goes away in itself. But in this case, you see it's very severe because this child has problem with T lymphocytes. Also, papilloma infections, warts, W-A-R-T, warts, which are caused by HPV. They can be very severe in these patients, and many other infections, like this another infection and so on and so forth. Sometimes cancers. There is a cancer named Kaposi sarcoma that happens in HIV people. Why? Because T lymphocytes are also important in defense against tumors. All these things can happen if the person has low CD4 counts, sometimes in the mouth, and other types of cancers which are very uncommon in people. So these are things which happen in HIV positive people. So how can we help the person? Well, first we need to diagnose the disease, and for doing the diagnosis, we do an antibody test to see whether antibody is present against the virus. We check for the presence of viral antigens, and we also do PCR. PCR is the best method for diagnosing a lot of infections, like in the coronavirus, COVID-19. PCR was the best test that we had, and it checks for the presence of viral nucleic acids, and then you need to treat the patient with antiretroviral drugs. So that was the end of the story. In summary, just keep in mind you have primary deficiencies, those are genetic. We have secondary deficiencies, HIV is one of them. And then this table, learn this table, we'll have this one question from this table that separates the symptoms for different types of primary immunodeficiencies. And yeah, any questions?
about the AIDS.
for a very long time. Especially today, because there are a lot of antiviral drugs that people consume, the latent phase could be 30 years. And the person is HIV positive